Emergency Medical Minute presents Laboring Under Pressure.
Welcome to Emergency Medical Minute Presents. I'm Jeffrey Olson, a third-year medical student at the University of Colorado, and for today's episode, we will be playing more clips from our event, Laboring Under Pressure. If you have been following this series, you will recognize the voice of Dr. Kiersten Williams, who you heard last episode talking about postpartum hemorrhage. In this talk, she discusses some key pearls in managing hypertensive disorders of pregnancy. I am joined in studio again by Dr. Travis Barlock, who will be helping provide some commentary and answering additional questions about the topic. Without further ado, let's get into our first clip.
So my first case on this one is a 23-year-old female who comes in complaining about a headache that started a few hours ago. She says it's really nasty. She tried taking Tylenol, but it is not working. She does say, hey, I'm pregnant. She's not sure how far along because she hasn't had any care. She thinks it might be about 6 months. She has been feeling fetal movement for about a month. She's been taking Tums all day too because she's got this really nasty heartburn that is just not going away. Her initial vitals show a pulse of 89, blood pressure of 180 over 112, and O2 sats of 95% on room air. So what do you want to do? Identifying and quickly treating hypertension is really important. It is one of the leading causes of maternal and perinatal mortality worldwide. It complicates anywhere, I've seen even up to 10%, but most of the studies that I've looked at have said 2 to 8% of all pregnancies. And it's one of the leading causes of maternal death in the US. And as risk factors are increasing, the incidence is increasing. And one of the stories that I carry in my heart from COVID was an African-American woman in New York City who, during the initial phases when everything was shut down, she had elevated blood pressures and her OB sent her to the laboratory to get checked. She did an internet search. She saw that her platelets were low and her liver enzymes were up, and she could not get anyone to call her back. And her mom happened to be an L&D nurse at one of the hospitals in New York City. And she went there and they did not properly treat her. And even with her mom being a nurse on the deck, she died. And to me, that was horrific. So we can do a better job. And this came out a few months ago, despite knowing the risks. Even on labor and delivery, severe range blood pressure is only treated properly about 50% of the time. And we can do better than that. So there is a whole spectrum of hypertensive diseases of pregnancy, and they range from chronic hypertension, and this is someone who knows that they have blood pressure going into pregnancy, and that's definitely on the rise in our nation, to people who just, maybe they don't access care or they're getting their blood pressure taken on the regular. So before 20 weeks, their blood pressures happen to be elevated. And they may or may not have superimposed preeclampsia on top of that. Maybe they've got an exacerbation of their chronic hypertension. There's gestational hypertension where your blood pressure is up after 20 weeks, but your labs are good. There's preeclampsia without severe features, which means you have mildly elevated blood pressures and you've got protein in your urine, but your liver function and your kidney functions and your platelets are doing okay. There's preeclampsia with severe features where your blood pressure is, your systolics are above 160s or diastolics are above 110. You've got symptoms such as headache or visual changes or right upper quadrant pain, or you have lab abnormalities. And I work with 10 MFMs, and there are times when you will get 10 opinions on a patient as to whether or not she's chronic hypertension, maybe some superimposed preE, maybe not, maybe this is just an exacerbation. And it matters to us because our patients with preeclampsia with severe features, we do not like to go home the rest of the pregnancy. They get to remain with us. Whereas if they are chronic hypertension with superimposed preE, maybe they'll get to go home. This is an argument that you guys don't have to have in the ER. That's fine. We're happy to pick that out. And even we can't always agree on that one. But the big thing is to recognize is that there is an issue. So our definition of hypertension in the OB is different from the rest of medicine. I'm married to an internist. He's always shocked that, I get worried about elevated blood pressures. And he's like, yeah, man, my little old ladies live that way. It's like, not my ladies. So systolic blood pressures of 140 or greater, or a diastolic of 90 or greater on 2 occasions, 4 hours apart, is considered mild range hypertension in pregnancy. Severe range, when you've got a systolic that is 160 or greater, or a diastolic of 110 or greater, theoretically, these should be 4 hours apart. We are not going to ignore those. So even though the definition is 4 hours apart, you're not going to let that go 4 hours without doing something about it. You're going to recheck 15 minutes later and see if it's still there. Protein for us, 300 milligrams on a 24-hour urine, or protein creatinine clearance of 0.3 or 2 plus protein on a urine dipstick. I mean, it can be pretty simple. Things that you need to pay attention to. Headache's not going away with meds. And sometimes this can be a little difficult, especially in a patient with a history of migraines, but a lot of women will say, this is different from my migraines. Visual disturbances that last more than a couple minutes. It's really common for a pregnant lady to say, hey, I was laying down and I got up quickly and I saw these little white floaters, but they went away after a minute. But black spots in their vision, blurry vision, loss of vision. I've had patients that had come in and can't see out of one eye. Anything that lasts more than a few minutes needs to be evaluated. Right upper quadrant pain. And I've had ladies that have come in and said, dude, I've just got the worst heartburn in the world, because that's how they're explaining right upper quadrant pain. Pulmonary edema, or if their platelets are low. We start to perk up our ears below 150, but if they're below 100, definitely need to look into that. Renal insufficiency, especially without a history of creatinine of 1.1 or higher, or doubling of their baseline creatinine. Impaired liver function. You might see some ladies that live around the low range of AST and ALT. There is definitely some fatty liver out there, or just that patient population that is mildly elevated. But if their liver enzymes are doubling over normal, or if they're creeping up, keep an eye on them. Heme concentration and an LDH greater than 600 are not diagnostic, but it's something to also prick your ears about. It's not uncommon in Colorado to see someone with preeclampsia come in with a crit of 45. LDH above 600 means that they're heading or in HELP syndrome and they're breaking down those blood cells. So we've got a blood pressure that's in the severe range. What do you want to do with it? And we really want to get that treated quickly, because our patients are not little old ladies. They're not going to tolerate that 180s. Someone who's in her 70s with 180s has been there for a while and her body is used to that and functions that way. Someone who's in her 20s is not going to tolerate that very well for very long. And there's definitely a risk of stroke or other complications, abruption, things like that can happen. So we've got 3 main drugs that we like to use in OB. One of them is labetalol. And for severe range, we will often start with IV. It's really quick in onset. It is pretty benign as far as side effects. But if you've got someone who's already bradycardic, it's not going to be your best drug for them, because it's going to make them more bradycardic. You also want to avoid it in women with significant asthma, myocardial disease, especially if they're decompensated, cardiac function, heart block, as I mentioned, bradycardia. It's not going to be the best first-line drug for them. Oh, by the way, for labetalol, typically you're going to see protocols like 20-20-40, 20-40-80, 4 milligrams on doing it, because if it's not working after 20 minutes, you're going to move up a dose or you're going to give more. Hydralazine, 5 milligrams is usually a good starting dose, and different hospitals will have different protocols, but if that's not working, do another 5, another 10, give it about 20 to 40 minutes and through there. Even though hydralazine is effective, it can be sort of sneaky. I have seen patients get hydralazine, the first couple doses don't hit until like an hour and a half later, and then they tank and their kiddo's not happy. So just know that that can happen to you. But if you've got someone who's bradycardic or doesn't tolerate precardia very well, it is definitely a decent choice. Nifedipine actually has grown on me through the years. When I was a resident, I hated it, because you give someone precardia, they get a wicked headache, and then you're like, oh, great. You know, do you have a headache for preeclampsia or do you have a headache from precardia? But in the ER setting, it's amazing because it's oral. So someone walks in the door and you're trying to get an IV in them, you can give them a dose of precardia and you don't need an IV. It works quickly and it works well, but they might get a wicked headache. And then you can have your OB sort out whether or not this is, you know, preeclampsia or the precardia causing that. And also, our goal is not to get the blood pressure normal. You know, with all the blood pressure recommendations that are coming out, and even in pregnancy for chronic hypertensions, they're saying you should probably keep them closer to 120 versus 140, which has always been our sweet spot. If you've got someone who's preeclamptic or acutely severe range blood pressures, bring them down to the 140s. Don't bring them to the 120s, because probably that placenta has gotten used to that elevated blood pressure, and your kiddo is going to be cranky on the monitor if you drop them too low. And then when to start magnesium, and this is always a question. Get your OBs involved in this. I would think that for the most part, it's better to err on the side of starting magnesium, versus having someone seize on you. And I know that the ER docs that I work on them, like, seriously, their nightmare scenario is some pregnant lady seizing in the ER. They really dread that. Worst case scenario, if we figure out she's okay, we stop it. And we see that a lot. We get a lot of rural transports and they'll come down and we'll evaluate them. We're like, okay, you're fine. We'll take you off the mag and see what you do. Typically, your starting dose is going to be 6 grams. But if you've got a tiny little lady or you've got someone who's got some renal insufficiency, start her off with 4 grams and then follow with 2 grams an hour unless you've got some issues like the renal impairment or they're not making good urine output. And then you're going to run them at 1 gram an hour. These were pimping questions when I was a resident. Who does not get magnesium? The biggest one is myasthenia gravis because it really can be bad for them. Hypocalcemia, renal failure, like if it's severe renal failure, cardiac ischemia, heart block, or myocarditis. With that, these are patients that probably really deserve a good maternal fetal medicine consult. Get them involved. They're happy to help you out.
All right, Dr. Barlock, we just finished listening to clip 1 of Dr. Williams' talk. First question for you. We learned that hypertension and the associated complications are one of the leading causes, if not the leading cause, for maternal mortality. Just looked it up. It's 31.6% of maternal mortality is caused by hypertensive disorders of pregnancy. How does hypertension cause mortality?
So specifically in pregnancy, hypertension is related to a number of different conditions, which can all individually be life-threatening. So the focus of the talk is primarily on preeclampsia with severe features, and eclampsia. Eclampsia is a life-threatening condition which can cause these seizures, which, like I said, are life-threatening. Then also, I always think of those conditions as on the spectrum with HELP syndrome. And so HELP syndrome is hemolysis, elevated liver enzymes, and low platelets. And in that condition, there can be swelling and engorgement of the liver, and that can lead to rupture. Also, hypertension in general can cause strokes. Strokes are life-threatening. Placental abruption is something that can happen and is higher in patients that are hypertensive. Additionally, there's the increased risk of postpartum hemorrhage, and then also coagulopathies like DIC. So those are kind of the main things that I think of as being the complications of having elevated blood pressures in a pregnant patient.
Yeah. Another thing we learned in Dr. Williams' talk here is that right upper quadrant pain, which we know is associated with preE, it's often misinterpreted as heartburn. Just kind of wondering, are there any other symptoms that are commonly misinterpreted in an obstetric patient?
Yeah, good question. Yeah, so the right upper quadrant pain or epigastric pain is being interpreted as reflux, is a common pitfall. And it is difficult because those patients also do have a higher risk of reflux anyway. But yeah, obviously our index of suspicion has to be high, have to keep our differential broad. I'd say the other symptoms that would be easy to maybe explain away if you weren't vigilant would maybe be shortness of breath and abdominal pain. So with shortness of breath, it would be kind of easy to trick yourself and say, oh, maybe the patient is, one, anxious, right? That's not uncommon for people to say. Patients who are pregnant are at higher risk for pulmonary embolism, for pulmonary edema, and also cardiomyopathies. And so I would say those are things that you need to at least think about and not let your guard down. And then with abdominal pain, it's almost like the flip side of it, where everyone might be anchoring on just the fact that they're pregnant and miss that there are non-obstetric causes of abdominal pain that can also be emergent. I mean, so a pregnant patient can also just have appendicitis or a bowel obstruction or something like that, and to not just blame everything on, oh, they're pregnant, that's why. So those would be the things. Yeah,
I agree. It's probably very important to just not anchor when you've got an obstetric patient. So next question for you, something interesting we learned here, common pimping question from Dr. Williams, is that myasthenia gravis is a contraindication for giving magnesium. This is, seems like two completely opposite, unrelated things. Is there a way that you can help us remember that connection?
Yeah, so one, from just the mechanistic standpoint, magnesium does interfere with acetylcholine release, and so if you can remember the pathophysiology of myasthenia gravis, then you would get that, it would worsen the condition because they already have impaired binding of acetylcholine and activation of the acetylcholine receptors. But pressing a way to remember it, I mean, the way I would do it is mg for magnesium and mg for myasthenia gravis. Now you just have to remember that you don't give it for that, but that would be like, what was the condition that I don't give it for? Mg and mg. So that'd be my little mnemonic for that.
Nice. Thanks for helping us remember that. All right, and for one last question for you, I thought we could go back to the case that Dr. Williams presents at the beginning. Just to refresh your memory, it's a 23-year-old female who is presenting with severe headaches. She is 6 months pregnant, and her blood pressure is 180 over 112. What would you do?
Yeah, so I think in every case, right, it's good to just always remember the basics. So that's going to be vitals, monitor, ABCs, that kind of thing. And so for this patient, I would get a full set of vital signs. Obviously, the ones that are being communicated right now are reflecting that she's hypertensive. And then I would get the patient on the monitor. We would get IV access. And then I would also continue with the full history and physical exam. But to more directly answer, I'd say the key for this is to first recognize that the patient is having a hypertensive emergency of pregnancy. And so, right, recognizing that we're already in a severe range for blood pressures. And then when you have these elevated blood pressures in a pregnant patient, right, we're thinking preE with severe features or eclampsia, just right off the bat. And then for this patient, just the symptoms of the severe headache and being in that severe range would make the criteria for preeclampsia with severe features met. So now we're already in that bucket, and so then it's casting the necessary net. So it's basically what are the diagnostics, and then what are the therapeutics. That's how I always kind of think of a workup. So for diagnostics, I would start off with a CBC, and then a CMP, probably an LDH, and then urine, and get a urine protein creatinine ratio on that. And then for therapeutics, I would just initiate a dose of labetalol for her. And then we're basically getting those labs back and trying to see, do we have complications like HELP syndrome or DIC, whatnot. So those things are what I'd do.
Great summary. All right, so we've got another clip from Dr. Williams here. Let's go ahead and listen to that now.
Case number 2 is a 29-year-old at 35 weeks, first pregnancy. And this is actually my one case that's truly based on a real case. This was when I was a med student. The anesthesiologist I was working with during my anesthesia rotation, this was his wife. She wasn't feeling good. She had a headache. She told him she was going to go to bed. He crawled into bed next to her a couple hours later, and a couple hours after that, she woke him up seizing. At this point, she's post-ictal. Her initial blood pressure is 156 over 98, pulse is 110, and her O2 sats are 91% on room air. So yeah, I do get crap. I don't want this patient to seize, or crap, she's seizing. Or I get worse language than that. Most seizures are going to be self-limited, and magnesium really is the best drug. It's better than phenytoin, diazepam, nimodipine in eclamptic seizures. If the patient doesn't have IV access, until you can get access, you can do a benzodiazepine or phenytoin, diazepam. I remember this from residency because occasionally we had people that would come into triage and seize on us. Until we could get an IV in, we'd do diazepam, 10 milligrams. IM-MAG is doable, but I will warn you, your patient will hate you. It is extremely painful. So if you're going to give IM-MAG, yeah, exactly. I saw that. First of all, mix it with lidocaine or something along those lines. And secondly, please split your dose between the butt cheeks, because you don't want to give 10 grams in one area. If you're really desperate, you're someplace where you can't have access to anything else, you can repeat it. But because the pharmacology of IM-MAG is different from IV-MAG, there's a higher chance of toxicity. Case number 3, and this is my last case, 32-year-old G3P2. She is 4 days postpartum, and she comes in with a headache. And this is actually similar to the case that set off the request for this talk with RER. The headache's frontal. She's been trying Motrin and Tylenol. It's not helping. She's got a history of migraines, but this is not her typical migraine headache. She delivered vaginally at 38 weeks. She got induced because she had some mild range blood pressure, but her labs were normal. Got sent home. On exam, pulse is 80. O2 sats are 92% on room air, and her blood pressure is 167 over 104. So don't forget that preeclampsia doesn't go away with delivery. Delivery is ultimately the cure for preeclampsia, but it can hang out for a little bit. So you're not out of the woods yet. 20% of all women will have some sort of hypertension in the first 6 weeks postpartum. And typically this is going to peak around days 3 to 6. So you probably will see a lot of postpartum patients that have some blood pressures, and just evaluate them for symptoms, look at their labs, look at their blood pressures. Most of these cases are going to resolve within the first few weeks, and almost all of them will resolve by 6 weeks. There is the occasional case that's going to linger. And if it lingers past 6 months, this is chronic hypertension. But if you're in the severe range, and especially if you've got a headache, visual changes, right upper quadrant pain, maybe your labs are off, these patients deserve 24 hours on MAG on LND just until things start to get better. And strokes can happen at this point. They are actually more likely to happen in the postpartum period. Most strokes will occur within 10 days, and usually that's within 2 days. And hypertension is the strongest risk factor for having a postpartum stroke. So at that point, actually, your treatment goal is a lot better. You don't have to worry about tanking a kid anymore. They're already cranky on the outside. So you can treat them to goal. And especially if you've got someone who's a chronic hypertension, talk to them about what their goal was before pregnancy and get them there. All the meds I talked about, precardia, labetalol, hydralazine, are all accepted in breastfeeding. There are occasions when they just don't cover. We've had some patients that are on hydrochlorothiazide for a short period. Maybe they need a little Lasix for a couple of days just to get some of the edema off of them. But enalapril is an ACE inhibitor that is actually safe for breastfeeding. So if you've got someone that does better on an ACE, enalapril is going to be your breastfeeding drug. And occasionally there is the patient that, none of these drugs are going to treat their blood pressure properly. And so typically we'll get renal involved. We'll have a good heart-to-heart with the patient that maybe breastfeeding is not going to be the healthiest for her because we need to get that blood pressure down and keep her safe. And so occasionally we do ask patients to quit breastfeeding, even though that's not our long-term goal. The other thing that was hotly debated a few years ago was whether or not to give these patients non-steroidals. Motrin is like our drug of choice in OB. We love Motrin postpartum, but non-steroidals do have that risk of raising blood pressure. And so there was a lot of discussion, and the party line these days is go ahead and give the Motrin, adjust the meds around it if needed. The thought is that giving Motrin is way better than sending someone home on a narcotic for a vaginal delivery, because we're really trying to keep them safe in that respect too. The other key thing is make sure these people are followed up closely. These are not people that can see their providers in 2 weeks. We really want them to see their OBs within a day or two, or their primary care, someone that can keep an eye on that blood pressure and make sure that they are safe. Just a few things to mention otherwise. These patients, part of the pathophysiology behind preeclampsia is leaky capillaries. We all know that they're swollen, but they can go into pulmonary edema really quickly. So watch your fluids on them. You might want to run them a little dry, and definitely be careful with boluses. And it is a fine line for someone that is technically dehydrated, but you give them fluids, it goes straight into their third space and it can send them into volume overload. Once that uterus is out of the pelvis, it can compress the blood vessels. So if you've got a pregnant lady, going back to our cardiac talk, and she's in the ER and you're working on her, make sure that she's in a lateral position. Old things used to say left lateral, new stuff looks at ultrasound and blood flow. Either side is fine, or you can have them sitting straight up. If you've got someone that needs to be prone, you can put a folded towel under their hip. It can give you enough displacement to help. And usually some things that can help you decide whether or not a patient needs more displacement. If she's really nauseated laying on her back, she's getting compressed. It's those baroreceptors that are setting off a vagal response. So that's your clue that she needs to be displaced a little bit more. And that's for the ones that are conscious. And as I said earlier, watch dropping that blood pressure too much, too quickly. That kiddo is going to complain on monitor.
All right. So we just finished clip 2 of Dr. Williams' talk. Want to check in with you again here about some of the points that came up. The first is the idea of managing a postpartum patient that presents to the ED. Let's say you have a patient that's coming in and you know they're 3 days out from delivery. You don't know if it was C-section or vaginal delivery, but you know, for one, that is their highest risk of stroke is within those days. But what else are you thinking about with a patient that's coming in, and maybe that's all the information you have is they're 3 days out?
Well, yeah, I mean, I guess just more broadly, like what are the common postpartum complications? And so I think of bleeding first, so postpartum hemorrhage, and then infection is always possible as well. And then obviously the former talk, right, we're talking about how there can be postpartum preeclampsia and all the other hypertensive disorders of pregnancy. They're still at risk for having blood clots, so I would think of the risk of pulmonary embolism specifically. And then the heart is also at risk of going into a postpartum cardiomyopathy, which is basically just a heart failure that's related to it. And so I'd be considering that. They can be anemic. They can have retained placenta, which would again be a patient who's having that postpartum hemorrhage. And then there's more obscure issues like thyroiditis, and then there's things that are just related to the nature of the delivery itself, like was there an episiotomy that was done, is there pelvic floor dysfunction, and then other pregnancy-related things like complications related to breastfeeding and whatnot. But as far as the life-threatening conditions, those would be the ones that I'd think about.
Yeah, certainly a lot to think about. So another question for you. I know ultrasound is very important for managing the obstetric patient. They get very regular ultrasounds, but I'm kind of curious how you're using ultrasound in the emergency department with an obstetric patient. Let's say that they have hypertension, and then also, do you ever use it postpartum?
Yeah, interesting. I mean, so yeah, like you said, ultrasound is very useful during the prenatal, perinatal period, and we in emergency medicine use ultrasound all the time. For me, in my practice, in a patient who comes in postpartum, who's hypertensive, the role of ultrasound is probably more limited. I think that there is utility depending on what you're suspicious for. So if you're worried about liver rupture, then, I mean, you could do a basic fast exam and see, is there a bunch of free fluid in the abdomen, even though it hasn't been validated in that. Basically, fast exam is really answering one question, which is there a belly full of blood? And so you could use it for that. And then similarly, if they were super short of breath and you were worried about either this phenomenon of pulmonary edema or they have a cardiomyopathy or something, then yeah, I mean, you could use ultrasound and help answer the question of do they have really wet lungs? Is their heart not squeezing effectively? And so it's almost like the non-obstetric ultrasounds that you could be using in that patient that would be helpful if we're talking about the postpartum patient.
All right, one last question for you. Let's say you have a patient that you're starting on magnesium. We know magnesium is not the most benign drug out there. How are you monitoring that patient while they're receiving their magnesium to make sure they're not developing some sort of toxicity?
Sure. So the first thing that comes to my mind is the cardiac monitoring. So I would have this patient on telemetry, and then this patient is also presumably in one of these hypertensive disorders of pregnancy, and so they should be getting routine, I'd say probably at least like Q10-minute blood pressure checks. And then lastly, for signs of magnesium toxicity, I would do frequent neuro checks on the patient as well, maybe every 30 minutes or so. I'd probably go in and check and make sure that their reflexes are appropriate and that they're not deteriorating.
Great. Well, I think we'll wrap it up there. Dr. Barlock, really appreciate you meeting me in studio today. It was great having you.
Thanks for having me.
And once again, I've been Jeffrey Olson, and this has been Emergency Medical Minute.